got last two speakers. We said at the beginning that we're going to go a bit long today because we've got such a power-packed team and so many issues we want to cover. So engineer Martin Weiss from Gembi Health in South Africa, whose organization is enabling mobile health across Africa. And then last but certainly not least, Dr. Jitendra Sharma on digital health initiatives in India from his very key role there many of you know about. Take it away, Martin. And while Martin's coming on, we'll probably go until noon New York time, so it'll be a 2-hour program. Thank you, Martin. And you're on mute at the moment.
Hi, thank you very much. Can you hear me now, I'm assuming?
Yes, it's great.
Right, thanks very much for this opportunity to show some of the technology that we building in Africa, and I think it's quite pertinent to some of the discussions going around telehealth. So my perspective is a little bit different. We're looking at a systems approach to telehealth for African countries. Just a little bit about me. My background is electronic engineering. I'm electronic engineer by birth and did a master's in biomedical engineering, but spent most of my working career in telemetry, which is also a type of tele service, but it's a the remote monitoring of electronic devices, mostly in mobile networks. And that was mainly in large corporates for profit, and I now find myself in a small non-profit public development company doing fantastic work in providing system support for health systems in Africa. So Gembi was started as a spin-off from our South African Medical Research Council, and currently we have around 28 developers and a staff complement of 130 in about 8 African countries where we have fairly large projects. We are a global partner and work closely with governments, universities, international donors, and other non-profit organizations. In March 2018, we established a collaborating center for digital health innovation. And the aim of that is to promote and support digital health innovation locally and within the region. And that was done with our South African Medical Research Council. So today, I'm really going to talk about 3 main topics. One is the challenges associated with mHealth in our region. Then what are we doing as Gembi to try and mitigate some of these challenges? And then I'll just show a quick 2 samples of projects that we're doing that use appropriate technology for the. So the challenges that face mHealth implementations in Africa are really interesting, and some research that I did, there are, over the last 9 years, there are over 400 mHealth pilots that were launched in 35 African countries at a cost of over $80 million. And when we talk about mHealth here, mHealth is a subset of digital health, and M applies to mobile. And of that, we have telehealth, which is a subset of mHealth for this category. So of these 400 mHealth pilots that were launched, only 3 of them scaled to a national level. And you know, if you think of that, that's a huge failure. And there are real reasons why this has happened. And those reasons, there's been some local research, as well as the World Health Organization has done research on why this has happened. And there are really 5 main categories what these challenges fall into. So and the main one, as far as I'm concerned as well, is governance. If you haven't got a governance structure and a national buy-in to what you're trying to achieve, there's very little chance of the project succeeding. It just doesn't become a priority within national health. The second is donor alignment. So very often donors and national ministries don't have the same strategy or the same agenda, which is challenging because it means that, again, you have donors who are prepared to fund projects in African countries, but if it's not of the same priority and falls within the strategy of a national Department of Health, there's very little chance of this thing scaling. Interoperability is mentioned numerous times by my previous colleagues, and it's a huge issue. I think one of the opportunities in Africa is that because we're starting more or less at the ground zero when it comes to digital health, we're able to leapfrog and ensure interoperability happens from day one. Whereas I think maybe in more advanced countries where digital health is already implemented and you have no interoperability, you have a bigger challenge of trying to migrate and integrate disparate data services. Sustainability also has been mentioned a number of times. So if we don't have plans of sustaining these technologies, they will not work. And that includes things like the type of batteries a device uses. You know, if we use a particular device and that is built around a battery that only comes from one particular supplier in Sweden, then it's not going to scale. You need to develop your technology which uses appropriate power supplies, so AA or AAA batteries, for example. And then most ministries also do not have the capacity to implement these kind of programs, and you need partners to help the ministries in implementing these programs. So how we work, or how we try to work, is we try to assist national and intergovernmental authorities to develop policies around digital health, mobile health, how to develop strategies in deciding what apps are important to implement, and then how do you implement these kind of projects so that they take ground, so that people understand it, there isn't rejection of the technology, and it gets adopted. This also provides direction for the implementers, for the donors, and for developers as well. We try to standardize everything on frameworks. South Africa has a particularly good normative health standards framework, and we try to promote this in other countries as well. It removes redundancy and duplication of efforts and allows third parties to work together for a common cause. And then we adopt interoperability standards based on a health information exchange model, which is also proposed by the World Health Organization. So that means that patient information is transportable, not only within a country, but across a region. And it's based on two of these protocols. One is called HL7, and the newer one is called FHIR, F-H-I-R. And then the fourth part that we try to do is we try to propose that all these technologies have some kind of built-in monitoring and evaluation in the implementation stages. So, and these are not necessarily only health metrics and indicators, but it's technology indicators as well. Things like what model phones are being used, when are they charged, what is the level of connectivity, how much data has been used. And these allow us to also have a look at what applications are more sustainable than others. So the first project that I want to go through is it's a solution that we built for South Africa, who's rolling out a program of community health workers. We under-resourced when it comes to clinics. We're under-resourced when it comes to medical professionals. Our clinics don't have enough nursing staff. So the model is around community health workers and getting the community health workers access to the National Department of Health data information. So what we have built locally is a bespoke app store. And the app store allows a healthcare worker a registered healthcare worker to log in and get access to particular apps that our National Department of Health can load into that app store. As part of this, what we've done as well is it's based on a technology called reverse build, which means that the community health worker can have zero balance on her mobile device, but still be able to download these apps and interact with the apps at no cost to the community health worker. This is important for operationally. How do you pay community health workers in large numbers stipends accurately and monthly? In this case, you don't have to worry about the data costs. It's all taken care of. It's also multi-tenanted, which means it's a tool that can scale down to organizations, to other partner programs, to pilot projects, and to user groups. So it can be run as a research tool as well. And built into this is a content management platform where third parties can access an editor where they can create user guides and content that gets served optimally for mobile devices. And my screen is frozen. So this is just some snapshots of the dashboard of what the Department of Health would log into. Here there's a demonstration company, Martin's demonstration company. I can see at any stage how many active users are on registered with my company, how many apps are loaded into the company, and how much data has been used. I can then see the names of the users. I can upload a list of names, and I can manually add a name if necessary. I can then associate, I'm just going to go back there, I can associate that user with a particular user type, and I can group them into provinces or any kind of tag that I wish to tag a group of users. I can also send instant notifications that pop up on the healthcare worker's phone, and as well as then here link any application that I have in my store down to particular users. So it becomes very flexible and very usable in managing community health workers. These are just some of the apps that we are working on either ourselves or through third parties to populate some of the applications and migrate them onto the App Store. So we have some user guides, national user guides over here. We have a national Road to Health booklet, which is a digital version of the paper-based digital Road to Health booklet. And then we have some bespoke apps for the Department of Health around stockout and around central medicines dispensing. Part of the work that we do is with the Medical Research Council, who also have research units like the African Health Research Institute, who are developing tracking applications for tracking HIV and TB patients. And these are research tools that, if scale, seamlessly can scale into a National Department of Health as well. The second project is for me, a really interesting project. It's a cross-border immunization tracking project that we implemented on the border of Kenya and Uganda. It was funded by USAID, and the client is IGAD, which is the Intergovernmental Authority on Development in East Africa. It was implemented in September 2018, so it's about 2 years ago, almost to the day. And we implemented it in 4 clinics in close proximity. They're about 4 to 8 kilometers apart. We trained 4 healthcare workers in this novel technology, which I'll show you now, and kind of left them alone to see how the others would adopt the technology. And today there are over 18 users who have upskilled themselves based on these original 4 healthcare workers. To date, there have been 15,000 new registrations. That's mothers registering their babies or infants with this immunization tracking application or program, with over 100,000 immunization events. And in the last 2 years, we've had, almost no downtime of the whole system. It's completely offline if necessary. It's also online. It has minimal power requirements. It's self-sufficient as far as power is concerned, either runs off mains or runs off solar, and it has internal batteries. It has a local storage and a local server, as well as a cloud storage, and it's designed modular for local support and maintenance.
Martin, 2 minutes to go. Thanks.
Okay, so this is how it works. The healthcare worker logs in. She has a NFC card, which is a typical kind of credit card that you have in your pocket. It holds the PIN for the healthcare worker. She types it in, and then she gets access to the app. The mother then arrives, who also has a card. She takes the card from the mother, taps it on the back of the phone, and gets access to the infant's immunization record. The healthcare worker can then do whatever she needs to do, give whatever vaccination she needs to give. And let's let this catch up. So it also tracks if an event wasn't recorded for out of stock reasons. And then finally, what the healthcare worker does is take the card, tap the card again to the back of the phone, and that writes the information onto the card. So the mother walks away with her health record on the card, as well as then stored on the cloud. Simple, effective technology. It reduces the time a healthcare worker spends doing administrative work from 15 minutes down to 3 minutes. So she can spend a lot more time with the patient. This is just a bigger solution, and I'll skip over that. So just to go back to what our landscape is, just to give you some context. So there is transport in the region where we work. It's just not the transport that we used to, but it's there, and if we use it properly, we can get technology to work wherever we need to. It means that when we want to use satellite technology, for example, we can't use technology that uses a 1.2 meter satellite dish, because I can't get it onto the back of a scooter. I need something more appropriate. There's also electricity. We just have to make sure that we use electricity appropriately in these environments. And finally, again, there is telecommunications. We just got to make sure that we use the telecommunications properly. And I think that is it. Thank you very much.
Wow, thanks so much, Martin. Great job. And